Picture this. You are evaluating a patient who came into the ER complaining of chest pain. On initial examination, obese gentleman, awake and alert, breathing on room air in mild respiratory distress. Temperature 100.6 degrees Fahrenheit. Heart rate 116 beats per minute. Respiration rate 27 breaths per minute. Blood pressure 90/50 millimeters of mercury. Oxygen saturation 92%. He suddenly became restless and confused, and oxygen saturation dropped to 87%. He became diaphoretic with audible wheezing and a sudden episode of hemoptysis. Skin was now cold, and reassessment of vitals revealed the following: heart rate 135 beats per minute, respiration rate 35 breaths per minute, blood pressure 76/42 millimeters of mercury. Describe the management of this patient. Good day, class. My name is Samantha Saunders, and the topic that me and my group was given is pulmonary embolism. A pulmonary embolism occurs once a clot is formed or another matter makes its way into the pulmonary artery. The introduction of the matter into the pulmonary arterial system initiates alterations of the blood circulation, such as decreased pulmonary arterial blood flow. This occlusion is usually caused by, but not always, deep vein thrombosis. So here is a diagram that will properly explain what is happening in the patient's body. So with the pulmonary embolism, a clot usually forms in the deep veins of the lower or upper extremities of the body. The pulmonary embolism occurs once the clot is formed due to the collection of red blood cells, which are knitted together by fibrin and platelets. This clot is firstly stable within a vulnerable blood vessel. It then breaks off, transforming the clot from a thrombus to an embolus. The clot then follows the flow of the blood, which will lead to the heart. This clot begins traveling through the inferior vena cava to the right atrium, to the right ventricle, to the pulmonary trunk through the pulmonary artery. So the occlusion of the artery makes it difficult for perfusion to occur, increasing pulmonary vascular pressure, which results in backflow to the right side of the heart and increase in right ventricular pressure. The artery makes it difficult for perfusion to occur. The embolism travels to the pulmonary artery, occluding the artery. So since perfusion is difficult to occur, this results in increasing pulmonary vascular pressure, which results in the backflow to the right side of the heart. So all of this will have a backflow. This leads to right-sided heart failure, decreased stroke volume, decreased cardiac output, and decreased blood pressure. Decreased cardiac output triggers the sympathetic nervous system. Like, hey, we need help up here. So the body then tries to compensate by trying to increase the heart rate, which results in sinus tachycardia and vasoconstriction. So this is the body's attempt to try to increase the blood pressure. The body will still fail because the embolism is occluding the pulmonary artery. We are familiar with perfusion and ventilation. This embolism causes ventilation and perfusion mismatch. In other words, a VQ mismatch. The abnormal gaseous exchange then leads to inflammation. Hyperventilation then comes into play because the gaseous exchange is thrown off of its regular schedule and supplies are cut. Hypoxemia and hypocapnia come into play due to the VQ mismatch, leading to respiratory alkalosis, what is found in ABG testing. The normal VQ ratio is 4 liters of air to 5 liters of blood. Three factors that were described as critically important to the development of a pulmonary embolism by Rudolf Virchow were abnormal blood flow, hypercoagulability, and altered vessel wall. This is known as the Virchow's triad. Although the Virchow's triad includes the three main components that contribute to the development of a pulmonary embolism, we still have other factors that contribute to this development, such as an acronym that we are going to name thrombosis. This can be used to easily remember factors that contribute to PE. T, trauma. H, hypercoagulability. R, recreational drugs or IV drug use. O, older patients or older persons. M, malignancy. B, birth control. O, obesity. S, surgery. I, immobilization, and S, sickness. Labs and diagnostic tests are also used to determine the diagnosis of pulmonary embolism. They are as follows. 1, ECG. 2, a chest x-ray. 3, ABGs. 4, INR. 5, PTT. And 6, D-dimer. Here is a diagram that displays the arterial blood gases and their normal values. First, we have the PaO2, which is the partial pressure of oxygen at 80 to 100 millimeters of mercury. We then have partial pressure carbon dioxide, which is 35 to 45 millimeters of mercury. Then we have the pH balance, which is normally at 7.35 to 7.45. The O2 CT, which is the oxygen content, is usually at 15% to 23%. The SaO2 or oxygen saturation is 95% to 100%. The HCO3 or bicarbonate is 22 to 25 milliequivalents per liter. Although the X-ray is used, it is only used to rule out other diagnoses and to get a proper look at the body. The ECG is used to exclude MI and pericarditis. What can be seen on the ECG is sinus tach and right ventricular strain, where the T wave is inverted. The D-dimer test, its regular value is 250 micrograms. The D-dimer test is used to determine if you have any blood clotting disorders. The prothrombin time test and the international ratio test are used to determine if your blood is clotting normally. The normal prothrombin time is 10 to 14 seconds. Now, back to the patient who was rushed into the ER for emergent care. Once again, you are evaluating a patient who came into the ER complaining of chest pain. Upon initial examination, obese gentleman, awake and alert, breathing on room air in mild respiratory distress. Vital signs were temperature 100.6 degrees Fahrenheit, heart rate 116 beats per minute, respiration rate 27 breaths per minute, blood pressure 90/50 millimeters of mercury, oxygen saturation 87%. He became diaphoretic with audible wheezing and sudden episode of hemoptysis. Skin is now cold, and reassessment vitals were as follows: heart rate 135 beats per minute, respiration rate 35 breaths per minute, blood pressure 76/42 millimeters of mercury. Now that you've heard and seen the scenario for yourself, It is time to analyze the situation and properly address each problem. Firstly, this client would seem anxious due to the increased heart rate and respiration rate to aid in the body's compensatory mechanism. But why does this client have a decreased level of consciousness all of a sudden? Decreased level of consciousness is due to low oxygen saturation. The brain needs to be perfused. It needs oxygen as soon as possible. So we can also note that the client would have a VQ mismatch. The clot is occluding the artery, making it difficult for oxygenated blood to pass through the pulmonary artery to get to the lungs and become oxygenated. Because the sufficient amount of blood is unable to pass through the pulmonary artery, where do we expect the blood to go? The blood will backflow to the heart. The heart will then attempt to pump harder to perfuse the body's organs. However, that won't work. Why? Because there is barely any oxygenated blood to get around the body. So of course, the blood pressure will drop lower and lower. The skin will become cold because there is no warm blood pumping through the body, and the client will hyperventilate to fight for oxygen to pass.
Okay, I will be talking about the treatment and management of pulmonary embolism. So the treatment can be divided into three parts: general treatment, anticoagulant, or also known as antithrombin and thrombolytic therapy. Thrombolytic therapy is essentially fibrinolysis, and we'll talk about it a little bit. I will go back to step one. So for general treatment, we use oxygen. You give oxygen for hypoxemia, and you give them fluids in case of circulatory shock. You have to avoid diuretics and vasolators because these drugs decrease cardiac output. And in pulmonary embolism, you usually already have a decrease in cardiac output, so it's very dangerous. You can use opioids for pain, but you have to be careful for hypertension. Then, number two, anticoagulants, which is very important. So, anticoagulants is essentially to prevent new blood clots from forming, and it is used in a minimum of 3 months. So, therefore, before introducing these new coagulants and their mechanism of action, it's actually important to revise with the coagulation cascade. So, the blood vessel now starts the coagulation. Cascade can either begin from an intrastic pathway or intrastic pathway when there's damaged tissue. So, either way, intrastic and intrastic pathway will lead to common pathway, which will help convert your clotting factor 10 to 10A. Intrastic pathway is from within, and intrastic is from damaged tissue. So, let us now move on to the anticoagulants used for pulmonary embolism. And two used are heparin and warfarin. Usually heparin and warfarin are given together with individuals who have pulmonary embolism. There are two types of heparin. There's on a fractured hip, which is administered intravenously, or there's a low molecular weight heparin, which is subcutaneously. So the mode of action of heparin is basically that it inhibits the action of production of clotting factors 10 and thrombin. And so essentially it inhibits the formation of the fibrin meshwork, warfarin. Warfarin, on the other hand, is taken orally and takes up to 5 days to have an effect. That is why we began warfarin with heparin. In order to wait for warfarin to have the effect, the mode of action of warfarin is that it is a vitamin K antagonist. and therefore it antagonizes as the synthesis of the clotting factors to 7, 9, and 10. So 2, 7, 9, and 10. So essentially, the effects of warfarin is also like heparin in that it inhibits the formation of the clotting factor 10 and also to thrombinin, thus preventing the formation of fibrin mesh. So we will begin the pulmonary embolism patient with heparin and warfarin, but then we will have to discontinue heparin and keep the patient on warfarin as long as the INR is okay and as long as the ionized above 2 and below 3. Now, the INI is another calculation for measuring coagulation activity in the body. And we will talk about INI in a more detail later. But essentially, to check the effects of warfarin, has in the body, you check the INR for heparin. You check a PTT, so when ion is above 2 and below 3, you can keep the patient on warfarin, and you have to monitor this person, and they continue warfarin for about 3 months, or lifelong, or if they are at a risk of developing another thrombus. I hope I made somewhat of sense. The third treatment now is thrombolytic therapy, and thrombolytic therapy is essentially fibrinolysis. So your aim here is to break down the clots. You're not preventing new clots from forming, but you're just breaking down the clot already. And this is used for acute massive pulmonary embolism and shock because you have it as an emergency. So again, we go back to blood tests. We can see what's used to check for coagulation activity in the blood. And we talked about D-dimers, we talked about INR, we talked about prothrombin, we talked about PT and PTT. So let's now look at these anticoagulant studies in more detail. And I will talk about 4 main ones here because these relate to these anticoagulant studies, and these relate to heparin and warfarin that I just introduced. These 4 are prothrombin time, the international normalized ratio IANA, the activated partial thromboplastin time, also known as PTT, and the bleeding time. So your prothrombin time, your PTs is measuring the activity of your clotting factors from the extrinsic pathway, and your common pathway, which the clotting factors produced by the liver. So you're actually assessing the synthetic function of your liver. Or you can also use prothrombin time to monitor the effects of warfarin, because warfarin targets the extrinsic pathway and your common pathway, as well as your international normalized ratio. Your INR is essentially like your PT, but it's a calculation and it's to monitor the effects of warfarin. So your extrinsic pathway, calling factors, in your common pathway, the normal INR means that you have normal coagulation. A higher INR means that you have less coagulation. Below a normal INR is when you are normal. You have normal coagulation, and a high INR means 2 or 3 means that you are less coagulated and you will bleed more easily. The third of anticoagulant study is that the activated thromboplastin time, partial thromboplastin time, and this is essentially to monitor the effects of IV heparin on coagulation. Number 4 is your bleeding time, which it is time to take to stop bleeding, which is below 10 and is normal for 10 or 9 minutes. Now I'm going to talk about nursing management of a patient with pulmonary embolism. As mentioned previously, the patient that we talked about earlier was given oxygen. As mentioned, because remember, medical management is anticoagulation therapy. Heparin and warfarin sodium has traditionally been the primary method for managing pulmonary embolism and thrombotic therapy. Urokinase, streptokinase, alloteplase are used in treating pulmonary embolism, particularly in patients who are severely compromised. Removal of the emboli may sometimes need surgical management. Surgical embolectomy, this is the removal of an actual clot and must be performed by a cardiovascular surgical team with the patient on cardiopulmonary bypass. Transvenous catheter embolectomy. This is a technique in which a vacuum catheter is introduced transvenously into the affected pulmonary artery, interrupting the vena cava. This approach prevents dislodged thrombi from being swept into the lungs while allowing adequate blood flow. A key role of the nurse is to identify the patient at high risk for pulmonary embolism and to minimize the risk of PE in patients. Now, we have to assess our patients. All patients are evaluated for risk factors for thrombus formation and pulmonary embolism. You ask health history. Health history is assessed to determine any previous cardiovascular disease. Family history. History of any cardiovascular disease in the family may predispose the patient to PE. Medication record. There are certain medications that can increase the risk for pulmonary embolism. Physical exam. Extremities are evaluated for warmth, redness, and inflammation. Nursing care for a patient with pulmonary embolism includes prevent venous stasis, encourage ambulation and passive leg exercises to prevent venous stasis, monitor thrombotic therapy, monitoring thrombotic and anticoagulant therapy through INR or PTT. Manage pain. Turn patients frequently and reposition to improve ventilation, perfusion ratio. Manage oxygen therapy. Assess for signs of hypoxemia and monitor the pulse oximetry values. Relieve anxiety. Encourage the patient to talk about any fears or concerns related to this frightening episode.
So I just want to give you guys a few current trends that are used to treat pulmonary embolism. So first we have rivaroxaban, which is given at 15 milligrams twice daily for 21 days. Then 20 milligrams daily. This is used to prevent pulmonary embolism or to treat deep vein thrombosis. So the prevention of blood clots and subsequent pulmonary emboli following knee or hip replacement surgery. Then we have apixaban. It is given at 10 milligrams twice daily for 7 days. Then 5 milligrams twice daily and 2.5 milligrams twice daily. Decreased thrombotic events associated with atrial fibrillation, including stroke and systemic embolization. When converting from warfarin, discontinue warfarin and start apixaban when INR is 2.0. So some newly discovered treatment options include catheter-directed thrombolysis or CDT. Then we have percutaneous cardiopulmonary support and surgical embolectomy. The catheter-directed thrombolysis or CDT is a newly found treatment that is minimally invasive. What this does is provide direct intravenous infusion of thrombolytics to the vein just adjacent to the clot. So this treatment is delivered through a percutaneous catheter. The percutaneous cardiopulmonary support is used to treat patients with a massive pulmonary embolism. So according to Korean Circ, the percutaneous cardiopulmonary support provides hemodynamic support via the femoral artery and the vein, using a closed artificial heart-lung system, which is usually composed of a centrifugal pump and a membranous artificial lung. Then we have a surgical embolectomy. This is the surgical removal of an embolus. It is usually an emergency procedure. We also have an inferior vena cava filter. It is placed within the vascular system to aid in the prevention of a pulmonary embolism. So this device stops blood clots from getting into the lungs. So before dismissing the client, we would need to educate them on how to properly care for themselves while at home. This would avoid the recurrence of the diagnosis. So firstly, we explain the medication to the client. Inform the client of the name of the medication, the dosage, its use, and the reason the client would be taking it. Secondly, we inform the client to come in for checkups on assigned dates to monitor the patient's blood values. These values will be monitored in order to determine if adjustments would need to be made to the medication. Specific values that will be monitored are INR and PTT. 3. Raise legs when sitting to promote venous circulation. 4. Eat healthy. 5. Stay hydrated. Dehydration can contribute to the sluggish blood flow. 6. We inform the patient to move around to increase mobility for proficient circulation throughout the body. 7. We inform the patient to wear compression stockings. This would prevent the blood from pooling within the legs. However, the patient should remove these stockings before bed. While asleep, the stockings should be removed because it can cut the circulation in the legs. 8. Stay away from vitamin K and potassium. Potassium increases the release of clotting factors, while vitamin K aids in the development of the clotting factors.